Welcome to an American Academy of Actuaries webinar. We're glad to have you with us today. Before we begin, here are a few tips to help you make the most of your experience. You can resize and move the individual windows on your screen to customize your viewing experience. Need to expand the slide area or media player? Click the arrows in the top right corner of the window. If you have a question at any time during today's program, use the Ask a Question box located at the bottom left of your screen. The slides and resources shared during today's webinar can be found in the Slides and Resources section located at the bottom right. For any reason during this webinar you have any technical issues, click the Help button under Engagement Tools in the upper right corner of your screen for On24 FAQs. Lastly, we value your feedback. Share your thoughts by taking the survey you'll see after the webinar or accessing it through the engagement tools in the upper right corner. At the Academy, we work to ensure every webinar constitutes an organized activity as defined under the U.S. qualification standards. We are dedicated to serving the public and the U.S. actuarial profession. The Academy informs the public of the role and value of actuarial work, delivers value to members, assists policymakers in the formation of sound public policy, and sets professional standards for U.S. actuaries. Please note, the presenter's statements and opinions are their own and do not necessarily represent the official statements or opinions of the ABCD, ASB, any boards or committees of the American Academy of Actuaries or any other actuarial organization, nor do they express the opinions of their employers. We're so glad you could join us. Sit back, relax, and enjoy today's program.
Welcome to the American Academy of Actuaries webinar, 2026 Health Insurance Premiums in Focus, Policy Changes and Impacts on Market Stability. Thank you for joining us today. I'm Corey Uccello, the Academy's Senior Health Fellow, and I'll be moderating today's session. Each year, the Academy publishes an issue brief that provides an overview of the factors expected to drive premium changes for the upcoming year. Our focus is on premium changes in the individual and small group markets, specifically for coverage subject to Affordable Care Act or ACA rules. We recently released our brief on projected 2026 premium changes, along with an infographic. This year, we also released a set of supporting materials that provide additional context. These include a short paper on strategies to achieve market stability, another on the interconnectedness of health coverage sources, and a timeline outlining the premium rate development process. We've included a couple of slides at the end with links to these and other related publications. And today's webinar will walk through each of these topics. And now let me introduce the other actuaries who will be joining me today. They are leaders within the Academy's Health Practice Council and were very involved with putting together our recent publications. Annette James is the Academy's Vice President for Health, and in this role serves as chair of our Health Practice Council. Jason Karcher is chair of our Individual and Small Group Markets Committee, and Tammy Chomchik is vice chair of the committee. Annette James will provide information on market stability, including what's needed to create stable markets and how different public policies could affect stability. Next, Tammy Chomchik will talk about the interconnectedness of the different health insurance types, sources for the under age 65 population, and how changes to the rules governing one type of coverage can have ripple effects on other coverage sources. She'll then give an overview of the premium development process. Then Jason Karcher will highlight the key factors that will affect how premiums will change in 2026. And we'll be leaving plenty of time for Q&A. Before we get to the topics at hand, I want to give a little more background on the Academy. In our public policy work, the Academy focuses on issues where actuarial expertise can provide clear, independent insight. Our goal is to offer objective, nonpartisan analysis to federal and state policymakers, regulators, and other stakeholders. We don't advocate for specific policies. Instead, we aim to inform the conversation with sound actuarial input. And importantly, we take care to consider the perspectives of the communities affected by policy decisions, so that our work reflects a broad understanding of both the technical and real-world aspects. The Health Practice Council leads the Academy's public policy work on health-related issues. We focus on several areas across the health insurance and healthcare systems, many of which are closely connected. Today's webinar centers on our work in insurance coverage and benefit design, which also intersects with issues of healthcare costs and quality. Beyond that, the Health Practice Council contributes to policy discussions on aging-related programs like Medicare and long-term care, public health challenges, health equity, and financial reporting and solvency. We also support professionalism in the actuarial profession, helping ensure that health actuaries continue to meet high standards in a complex and evolving public policy environment. The Academy's Health Practice Council is made up of several committees that carry out the core of our health policy work. One I want to highlight today is the Individual and Small Group Markets Committee, which is responsible for much of the work we'll be discussing today. The committee monitors federal and state legislative and regulatory activity and provides actuarial insights on proposals that could affect the individual and small group markets. One of its key annual projects is the development of the Premium Drivers Issue Brief. The committee also submits comment letters on regulatory updates and legislative proposals that could affect how these markets function. And now I'm going to turn things over to Annette, who will discuss market stability considerations. Annette, take it away.
Thank you, Corey. That was a great overview of the Academy's public policy goals, the Health Practice Council's priorities, and in particular, the focus of the Individual and Small Group Markets Committee. So let's turn to an essential attribute of a well-functioning health insurance market, and that's market stability. Affordability and access are usually cited as important health policy goals. However, without stability, affordability and access may be compromised. So it's important to understand what supports a stable market and what can threaten it. There are three ingredients to a stable individual health insurance market. First of all, adequate enrollment. When enough people enroll, claims become predictable and insurers can better price their products. Secondly, a balanced risk pool. That means not just attracting people with high expected claims, but also those who are relatively healthy. The more balanced the pool, the lower and more stable the premiums. And thirdly, a predictable regulatory framework is important. Rules that are consistent, reliable, and fairly enforced help create a level playing field and encourage insurers to participate. These components reinforce each other, and when they're in place, the result is more affordable coverage options, healthy competition, and long-term insurer participation in the market. Now let's discuss the concept of risk pooling in more detail, as this is really a fundamental principle of insurance. So let's first define it. What's a health insurance risk pool? Well, a health insurance risk pool is a group of individuals whose medical costs are combined or aggregated to calculate premiums. Pooling risks together allows the higher costs incurred by less healthy enrollees to be offset by the lower costs of healthier individuals. This can happen within a plan or depending on how premiums are set within a premium rating category. In general, the larger the risk pool, the more predictable and stable premiums will be. And that predictability is important for everyone, insurers, regulators, and consumers alike. Effective risk pooling can also help ensure that coverage remains accessible, even for people with chronic or high-cost conditions, without creating extreme variation in premiums. A related concept is adverse selection. So that's when people with greater healthcare needs are more likely to enroll than those who are healthier. This can happen when insurance is voluntary or when people can pick and choose among plans based on their expected needs. The problem is that when the risk pool becomes skewed towards higher cost enrollees, premiums rise. And as premiums rise, healthier individuals may opt out, causing premiums to rise even more. And that's what's often referred to as a premium spiral. And it's something that policymakers aim to avoid by creating incentives for a broad cross section of individuals to enroll, and by developing rules that minimize opportunities for adverse selection. This graphic here offers a simple but I think powerful illustration of how risk pooling works and why the individual market's risk pool requirement plays an important role. So on the left here, you'll see an illustrative health insurance market where everyone is in the same pool, healthy individuals, less healthy individuals, all together in the same pool. And premiums are based on the average risk across the group. But if plans are not all required to follow the same rules, and some are allowed to sidestep requirements such as essential health benefits or guaranteed issue, the market could become segmented. And in that scenario, healthier individuals might be more drawn to plans with fewer coverage requirements and lower premiums. And that's what's labeled here on the bottom right as non-ACA coverage. So that would leave a smaller, higher cost group in the ACA compliant market. And because this group would have higher average costs, premiums, and because this group will have higher average costs, premiums in that segment would be much higher than the combined group on the left and certainly the group on the bottom right. And this type of segmentation reduces the effectiveness of risk pooling and results in higher premiums for those who rely on comprehensive coverage, such as people with chronic or ongoing health conditions. The ACA's single risk pool requirement helps guard against this. It is designed to ensure that premiums reflect the health of the market as a whole, rather than allowing risk to be segmented in ways that could drive up costs and reduce access. That's one example of how market rules, when applied consistently, can help stabilize coverage and protect consumers. Talking about policies, there are a number of current policies that help promote stability in the individual market. Premium tax credits and cost sharing reductions play a central role in improving affordability. By lowering out-of-pocket costs, they help make coverage more attractive to a broader population, including healthier individuals, and strengthening the overall risk pool. The single risk pool requirement also ensures that premiums reflect the health profile of the market as a whole, rather than the risk level of each individual plan. And that supports competition based on price and quality rather than risk selection. Then risk adjustment complements this by compensating plans that enroll higher risk individuals. It helps maintain a level playing field and reduces incentives for health plans to avoid less healthy enrollees. And finally, uniform market rules such as guaranteed issue and the prohibition on rating based on health status. These rules ensure that people with chronic conditions can access coverage on fair terms. And they also help build a more predictable and stable market. Now, let's turn to some additional provisions of the Affordable Care Act that also play a role in supporting stability. So the essential health benefit requirements ensure that all comprehensive plans cover a consistent set of services. And that makes it easier for consumers to compare plans and ensures meaningful coverage. State laws and regulatory oversight, such as rate review, solvency standards, and consumer protections, reinforce fair competition and reduce the risk of market disruption. And finally, transparency requirements help consumers make more informed decisions. By promoting visibility into plan pricing and provider costs, they can also encourage price competition across the system. Taken together, these policies provide a framework that fosters enrollment, spreads risk, protects consumers, and supports insurer participation in the market. It's important to note, however, that they don't operate in isolation. They're totally interdependent. Weakening one area can strain the effectiveness of the others and increase the risk of market disruption. So now I'll give you a couple of examples of policy options that have the potential to strengthen the market. The first one I'll talk about is the expanded use of ICRAs, or individual coverage health reimbursement arrangements. If a broad cross-section of employees use ICRAs to purchase individual market coverage, it could help diversify the risk pool and stabilize premiums. But this approach will only work if the individual market is affordable and stable. Simply put, employers won't want to send their employees into a volatile or high-cost market. Another approach is reinsurance, or invisible high-risk pools. These mechanisms help offset the cost of high-need enrollees and lower premiums for everyone else. That can be especially helpful for people who don't qualify for subsidies. By improving the affordability for this group, reinsurance can draw more healthy enrollees into the market, again, strengthening the overall risk pool. On the flip side, there's some policies that could actually undermine stability because of the impact on the risk pool. For example, if the enhanced premium tax credits expire as scheduled, net premiums would increase across the income spectrum, which may discourage enrollment. And a drop in enrollment could lead to a less balanced risk pool and put upward pressure on premiums for those who remain insured. Stricter eligibility verification requirements could have similar effects by making it harder for some individuals to maintain coverage, and those with higher health needs may be more motivated to meet the stricter requirements and remain enrolled than less healthy individuals. And in other words, it may increase adverse selection. As we saw in the earlier example, the increased availability of non-compliant plans could also draw healthier individuals out of the regulated market, further shifting the risk pool and increasing premiums in the ACA compliant market. And proposals to allow cross-state sales of insurance could weaken state-level consumer protections and oversight, particularly in states with stronger regulatory framework. And so that, again, could lead to market fragmentation and increased stability. So each of these policy changes or potential policy changes could lead to higher premiums, reduced insurer participation, and fewer coverage options, especially for people with ongoing health needs. So while many provisions can help support market stability, certain policy changes could have the opposite effects, depending on how they are implemented, of course. And with that, I'll turn things over to Tammy, who will discuss how different health coverage sources for under age 65 population, Connect, and she will also walk us through the premium rate development process and timeline. Tammy?
Okay, thanks, Annette. That was a great overview of how important it is to have a balanced risk pool in keeping rates affordable, as well as having a regulatory framework that promotes stability and competition. So in this next section, I'm going to talk about different sources of health coverage for individuals under 65 and how these markets can actually be interconnected with each other. So on this slide, this shows the three primary sources where individuals under 65 get their coverage. These aren't the only sources, but these are the primary sources. So coverage that's through an employer-sponsored plan, the individual market, and Medicaid or CHIP. And over time, individuals will move between these sources as things such as their employment status, their household income, family status, and other things change. And at times, they may even become uninsured. And these are three separate markets. They're largely governed by their own laws and regulations, which can lead policymakers to think about them in isolation. But these markets are actually interconnected in ways where making a policy change in one market could lead to a ripple effect and sometimes significant in one or more of the other markets. And we'll look at some examples of this over the next few slides. Okay, so employer coverage is the largest, or the place where the largest number of individuals under 65 receive coverage through either their own employer or through a plan that's offered by an employer of another family member where they're eligible to enroll either as a spouse or a dependent. And there are several key policies related to the employer-sponsored market that have cross-market implications that are listed here on the slide. For example, the ACA defines coverage as being affordable based on the required premium contribution that employees have to make. And that premium contribution is compared to a specified percent of their household income. That percentage changes from year to year. If the employee contribution is below that percentage of income, it's deemed to be affordable. And if that happens, or in those cases, individuals are not eligible to receive premium tax credits in the individual ACA market, even if their income's at a level where they otherwise would qualify for those premium tax credits or premium subsidies. So therefore, if policymakers were to change the definition of affordable employer coverage, or even remove this firewall to subsidies altogether, it would impact the number of people that would be able to perhaps find coverage in the individual market with a lower net cost than their employee premium contribution for their employer plan. This would impact enrollment both in the individual market and the employer market, and likely change the risk pool composition in the individual market. And when that risk pool composition changes, premiums would in turn change for that market. So you can see that these two markets are actually interconnected in a way where a policy change in one impacts the other. And similarly, if the other policies listed here were to be modified, one or more markets beyond the employer-sponsored market would also be impacted. So Medicaid and CHIP, these are programs that cover low-income individuals and some other vulnerable populations. They're jointly regulated both by federal and state governments, so therefore there can be significant variation in policies from state to state. Key Medicaid or CHIP policies that can impact other markets are listed here. I'll walk through a couple examples. For example, if a state were to expand Medicaid under the ACA to the childless adult population, that's likely to reduce the number of individuals that are uninsured, because they would now become eligible for Medicaid and cover more low-income individuals as a result. So people who become eligible for Medicaid are no longer eligible for premium subsidies in the individual market. So some people that may be currently enrolled in the marketplace would shift over to Medicaid, where the benefits are typically broader, cost sharing's lower, and this shift in enrollment would reduce the individual market enrollment and change the composition of that risk pool, again, in turn impacting the premiums in that market. Another example would be changes in Medicaid redetermination processes. This could impact who among those that are currently enrolled in Medicaid would be eligible to remain in Medicaid, which in turn would impact who's eligible for subsidies in the individual market, again, changing the composition of that risk pool and premium. And finally, the individual market. This largely serves those that do not qualify for Medicaid, do not have access to employer-sponsored coverage, or are self-employed. In this market, the premium tax credits are made available to certain lower income individuals if they enroll through the exchange. But these tax credits currently are not available to individuals who are eligible for Medicaid or have access to what's called affordable employer-sponsored coverage, as I defined earlier. You can see that there's a number of policies that impact the individual market that have cross-market implications, and most of these policies impact affordability. So they influence whether individuals opt to enroll in coverage versus choosing to go uninsured. For example, if the rules around access to premium credits, both in terms of who can access the credits and the size of the credits that are available, change, similar to what's scheduled to occur next year in the ACA market, this can lead to consumers making different purchasing decisions. So changing these rules may impact decisions on whether they enroll in individual coverage, go uninsured, or even whether they elect to take employer coverage that they may be eligible to enroll in. Now I'm going to talk about ICRAs for a minute. Annette touched on them earlier, but ICRAs are relatively new. They're a vehicle that was introduced under the first Trump administration, and they allow employers to contribute funds without being subject to payroll tax into accounts that they set up for their employees. So the employees can then use these funds in their account to purchase coverage in the individual market. But if they do use these ICRA funds, the individual cannot access premium tax credits. So if there's policies that are in place that both promote a stable market and support lower premium rates in the individual market, these ICRA arrangements may become more attractive to employers than offering group coverage, which in turn could increase the size and improve the stability of the individual market. However, if policies are implemented that lead to higher individual market premiums or market instability, employers are going to be less likely to introduce these options for their employees. And I mentioned earlier Medicaid expansion policies and how they would affect not only Medicaid, but the individual market and the uninsured. Likewise, there's other changes to Medicaid, such as tighter eligibility rules or revising the procedures that can make it more burdensome for individuals to enroll in Medicaid. These could also affect not only Medicaid, but both the uninsured and enrollment in private coverage. And the size of the enrollment shifts are really going to depend on the particular changes that are implemented here. So to summarize all of this, it's really important for policymakers to understand that decisions they make in relation to one of these markets really have broader implications and impact more than just that market. Now I'm going to shift for a few minutes and look at the rate development process and the timeline under which it takes place. So before I start, I want to clarify that insurers develop premium rates. They don't calculate premium increases. They file those rates. They go through a rate review process that evaluates whether the rates are reasonable based on the expected costs. But consumers, policymakers, and even the media, they tend to focus on premium rate changes. In other words, how much the rates go up from one year to the next. But those changes are really, just a byproduct of comparing premium rates in one year to the next, and they reflect how the underlying cost drivers evolve. At the highest level, premium rate development is a process that consists of analyzing prior claims experience and then making adjustments to reflect future expected claim costs. But if we dig in a little deeper, there are actually subcomponents that go into setting premium rates. First, who is the expected population that's going to be covered? What's the composition of the risk pool? Is it a healthy mix, or is it a risk pool that's skewed towards those who have greater health needs? Next, the insurer will project medical costs for that expected population. They'll use prior experience and trend assumptions to project those forward and adjust for differences in the morbidity underlying the population of the experience and that of the population that's expected to be covered during the period for which the rates apply. They then need to add things like administrative expenses, taxes, margin for profit and surplus, and of course, all of the applicable laws and regulations are going to influence these components. Jason's going to talk here in a little bit about this in more detail, but I wanted to mention that any of these components can change from year to year based on what's going on in the healthcare system, as well as changes in laws and regulations. So this slide illustrates the key internal and external deadlines in the premium rate development process. I'm not going to walk through each of these steps, but what's key here is that developing products and premium rates is really complex. It takes a lot of time. And insurers will typically work backward from the filing deadline date to determine by when they have to develop their products and design their plans and analyze prior claims experience, project that experience forward, and prepare their rate filings for documentation for submission. Notably, you can see that this process starts more than a year in advance of the effective date. And it's kind of interesting that we're sitting here today talking about 2026 premium rates, but really in a couple months, insurers are going to already be starting to plan and work on 2027 products and premium rates. The premium rate development process needs to account for things such as legislative and regulatory changes. These policy changes that occur late in the rate development process can create significant challenges, not only for carriers, but also the regulators that have to review them, finalize the rates, and get everything ready for open enrollment. And depending on the policy changes that are made, it can take more than 6 weeks for an insurer to update the rates and other internal requirements that they need to reflect policy changes. So the earlier that legislative and policy changes are made, the more readily they can be reflected in. Before I move on and hand things off to Jason, I wanted to acknowledge a common question that's coming up a lot lately, and that's how late is too late for Congress to act if the enhanced premium tax credits were to be extended into 2026 and get those changes into the 2026 premium rates. So if we work backward, the final limited data correction window is in mid-September, so really just a little over a month. So for rates, they need to be finalized and submitted by that point. And if the subsidies are extended, insurers could need up to 2 weeks to revise and refile their rates. This would mean action from Congress needs to take place no later than the end of August to give enough time to submit the revised rates and, again, for the states to review them and approve them, which admittedly is a very tight timeline. So I'm going to repeat that. Given the current filing deadlines, Congress needs to act by the end of August to extend these premium tax credits if they want to ensure enough time for the 2026 rates to reflect the extension if they were to pass such legislation. There could be a little wiggle room, perhaps maybe a week, but that's if that mid-September deadline were to be extended. But the bottom line is that any action would still need to happen relatively soon to give insurers and states enough time to do this. So with that, I'm going to turn things over to Jason, who's going to talk about the factors that are likely contributing to the 2026 premium changes.
All right, thank you, Tammy. So now it is time to turn to the findings in our premium drivers issue brief, which outlines factors expected to influence premiums for the 2026 plan year. Now, this issue brief and today's webinar describe key factors that could contribute to premium changes for the 2026 plan year. They reflect general actuarial observations and insights and are not based on any specific rate filings. These materials should not be and are not intended to be used or relied upon by actuaries and insurers who are developing rates or by regulators reviewing them. Actual filings may reflect different or additional considerations. However, we do anticipate that most rate filings will be affected by some or all of the issues outlined here. For the issue brief, we categorize premium drivers into three main categories. First, we looked at medical trend factors, so items that are reflective of how much care is used, how much healthcare costs for the different healthcare items and services that are covered under insurance. Second, we discuss risk pool composition factors, which are reflective of expectations surrounding the overall health status of the people who purchased that insurance. And then other factors that are more likely to uniquely affect individual rate filings and or reflect specific circumstances as opposed to general trends. Key medical trend factors that are influencing 2026 premiums include general inflation, the continued high rate of growth in drug spending, and increased use of behavioral health. General inflation affects the input costs for healthcare, overhead, supplies, labor costs. It's one of the core elements of year-over-year cost growth. Of course, many provider contracts span multiple years, and inflation's contribution to premium growth can reflect multiple years of variance from expectations. So a great example of that was our recent, there are likely still a couple filings out there that are reflecting some of the high inflation trends from 2022 and 2023, rolling those finally into new rates. Cost growth for drugs continues to be significantly higher than most other medical services. Underlying drug prices historically have risen faster on average than inflation, both before and after drug rebates. In addition, new and high-cost therapies continue to put upward pressure on trends. This includes relatively low frequency but extreme cost treatments, such as cell and gene therapies that can approach well in excess of six figures, as well as higher utilization but only moderately high cost therapies. A great example of that is newer weight loss medications that are a frequent topic. So beyond prescription drugs, the increased demand and utilization and cost of behavioral health also puts upward pressure on premium rates. This is driven in part by federal and state mental health parity laws, and an increased interest in services and heightened enforcement of these laws causes issuers to expand provider networks, which can lead both to increased utilization and higher provider reimbursement, which may be necessary to attract a sufficiently large network to meet the demand from health plans members. Moving on to risk pool composition. Composition in the risk pool is likely to vary between the individual and small group markets, and the change in that composition from year to year is also expected to vary. We'll talk about the individual market first. Three major drivers of risk composition changes in the individual market include the recently finalized marketplace integrity and affordability rule, the pending expiration of enhanced premium tax credits, and the longer-term effects of Medicaid redeterminations. Looking at a little more detail, the marketplace integrity rule institutes an array of provisions targeted at verifying enrollment, eligibility, and/or active attention to subsidized coverage. Most of these provisions take the form of administrative hurdles and do raise adverse selection concerns, as healthier individuals are more likely to decide that the extra time and effort needed to comply with new requirements is not worthwhile, leaving a less healthy risk pool, which can lead to higher premiums. Along similar lines, the pending expiration of enhanced premium tax credits is also expected to reduce enrollment significantly. As net premiums increase, healthier individuals who are more likely to be price sensitive and more price sensitive than other individuals are then more likely to decide that the extra cost is not worthwhile. This again creates adverse selection and will lead to higher premiums as well. The influence of Medicaid redeterminations is less straightforward. 2026 marks the first year where issuers have experience for new enrollees returning to the market following the end of Medicaid continuous coverage requirements in early 2023. In some states, this cohort has been younger and healthier than expected. This would improve the risk profile and put downward pressure on premiums. In other states, the cohort appears to have had higher health needs relative to expectations, which would put upward pressure on premium rates. This is very specific to, again, how costs compare to expectations. Moving on to the small group market. Dynamics in the small group market differ significantly from those in the individual market. While the individual market has grown significantly in recent years, the small group market has experienced slow but steady reductions in enrollment from year to year to year. This appears to be strongly influenced by the presence of alternative coverage sources. The steady rise of self-funding approaches for small groups, most notably level funding, tend to draw the lowest cost groups out of the small group market, further reducing its size and increasing costs and premiums for the groups that remain in that fully insured small group market. Individual coverage health reimbursement arrangements, or ICHRAs, which we've talked about before, and qualified small employer health reimbursement arrangements, or QSARAs, have also received significant publicity in recent years. Both of these arrangements serve to shift lives from the group market into the individual market. Now, the effect of ICHRAs and QSARAs on small group markets is dependent on the groups that are attracted to individual market coverage, which typically has higher deductibles and drug cost sharing levels in small group coverage. If this proves to be small employers with higher cost employees that take this option, the shift could improve small group risk pool, but could potentially have negative impacts on the individual market. At the same time, if this appeals more to healthier groups, then you would have the opposite effect. Beyond medical trend factors and risk composition factors, there's a few other factors that are worth mentioning. that can significantly affect specific filings. All healthcare is local. State and local factors, such as the number of issuers in a region, provider consolidation, facility closures and expansions, state legislative or regulatory requirements, any and all of these can affect filings for coverage in those specific areas. Some, such as provider consolidation, reduced competition, or new state-required benefits, are more likely to cause premiums to grow faster. Others, such as a state 1332 reinsurance waiver or provider reimbursement rate caps, may put some downward pressure on premiums. These effects are, again, likely to vary and be specific to the locality in question. Finally, I'd like to discuss the role that uncertainty plays in premium rates as well. Insurance is designed to protect against risks, and insurers set premiums to reflect that expected risk. Think of it as ensuring that the issuer will be able to take in sufficient premiums to cover all claims in a certain high percentage of the time. That percentage can be thought of as the issuer's risk tolerance. That's the percent of time they want to invest extra money in or want to be forced to versus have premiums cover that cost. In times of greater uncertainty regarding the rules that govern the market, the makeup of the market, or the level of cost growth in the market, higher risk margin is necessary to ensure that the issuer can provide that same overall level of financial protection at their chosen level of risk tolerance. This isn't gratuitous increase of premiums. It's accounting for the risk that is being insured. So now I will turn things back to Corey, who will wrap up the formal presentation and then moderate our Q&A. If you haven't posed your question yet, now would be a good time to do so.
Thank you, Jason. Whoops. Thank you, Jason, Tammy, and Annette. Before we get to the Q&A, I'd like to wrap up with a few key takeaways from today's discussion. First, market stability is foundational. It supports affordability, insurer competition, and consumer access in the individual market. Without it, everything else becomes more difficult. Second, premium increases are likely in 2026. Rising medical costs, increased drug spending, and a worsening risk pool are all contributing factors. Third, policy decisions really do matter. The expiration of enhanced premium tax credits and stricter eligibility verification rules could significantly reduce enrollment in the individual market, especially among healthier individuals, which in turn puts upward pressure on premiums. Fourth, we can't treat coverage sources in isolation. The interconnectedness of Medicaid, employer coverage, and the individual market means that changes in one area can ripple through the others, affecting both enrollment and pricing. And finally, early policy clarity helps. When rules and legislation are finalized in a timely way, insurers can price more accurately, which helps reduce volatility and improve stability across the market. And so now it is your turn, as Jason mentioned. If you haven't already done so, I encourage you to enter your questions in the Q&A tool on your screen. And let's start out with a question about some of these different state-related effects. One thing you mentioned, Jason, was the presence of 1332 waivers. Can you describe how the kind of interaction between the expiration of the enhanced premium tax credits will work in states that have 1332 waivers and use those waivers for reinsurance programs?
Certainly. So state 1332 waivers function by an investment of essentially state funds that leverage federal dollars in the forms of reduced premium tax credits and cost sharing reduction subsidies, which we don't have, but if they were there, they would count. And to use that in some way to affect reductions in premiums. The math is complicated, but a good heuristic to use is that how much money the state needs to pitch in as far as the total cost of whatever program is there is roughly equal to the percentage of subsidized individuals in the market. So the enhanced premium tax credits are expected to significantly reduce the number of individuals with subsidized coverage. And it's less likely to have a significant effect on the number of people who have unsubsidized coverage. We've been fairly constant over time. What that's going to mean is a higher percentage of people are unsubsidized, a lower percent of people are subsidized. And so the state is going to have to pitch in more to cover that extra cost. Now, that really depends a lot on how the state chooses to fund their waiver, but that's a much longer discussion we don't need to go into.
Thanks, Jason. We did get a question regarding coding and the effects on any trends. Now, coding risks in the ACA, the individual market and small group market is much different. It's a different system than what happens under Medicare Advantage. I know there's a lot of attention right now being paid to risk adjustment in Medicare Advantage and concerns about coding in that program. Are there any similar concerns with the individual or small group market along those lines? And can you kind of explain maybe how the individual market risk adjustment may differ from that in MA? And I'll actually answer part of that. It's partly that one of you guys can correct me if I'm wrong. I think that for the individual market and small group market, this is a budget neutral kind of exercise, and that's not necessarily the case in Medicare Advantage. But does anyone have anything to say just on the coding in particular, or even more broadly, issues regarding risk adjustment in the ACA programs?
You are right. Risk adjustment data validation is a very different game for ACA markets. MA, a risk adjuster is set beforehand, and based on what you code and what you support, that gives your risk score. That risk score is multiplied by a base rate, more or less, to get your total revenue that you earn from that member. That doesn't have to be balanced against anything. It's supposed to target 1.0, but if they miss, there's no real enforcement mechanism for that. And CMS's approach there is very much, we're going to look at what you have. Any coding that we can't find support for, we're going to say you didn't earn, and we're going to claw that money back. So it's very focused on being correct about all of the risk adjustment diagnoses that you have in your data. In the ACA, risk adjustment, as you noted, is revenue neutral. And so the risk adjustment data validation doesn't take this absolute approach that you see in Medicare Advantage, but rather it sets everything against the market average. So if you have a lot more coding than market average, then that's when they'll try and claw something back for you. If you have a lot more excess coding, if you have a less excess coding, then you may get something in return to get you back a little closer to the center. What we have seen is a gradual decrease in those error rates, but not moving that quickly towards zero. The incentives don't necessarily align well as far as making issuers want to be 100% accurate. given the way that the payments balance out. I don't know.
Okay, we got a question on ICRAs. Hold on just a second. So are there any thoughts about the potential to make ICRAs mandatory and moving the employer market to one that's more kind of ICRA-like, where it's using the individual market to put the employees? Are there risks and or opportunities in that kind of approach? Tammy, do you have any thoughts on this?
Sure, I'll start. It's an interesting question. So, Corey, meaning just eliminate the employer-sponsored market altogether and mandate ICRAs?
Yeah.
Yeah, it certainly would stabilize the individual market risk pool because it would become very large. It would, detach the connection between someone's insurance coverage and their employer. So as they change jobs, they would be able to keep their same plan, presumably with the same network, and there would be less disruption in having to find a new primary care provider if their new employer and employer coverage had different network of doctors and hospitals. Boy, I don't know, Jason or Annette, is there anything that's coming to mind that you can think of?
And one of the big challenges you would face with that type of approach is looking at large employer coverage, which is for the most part done through self-insurance. So if you make all of those, and some of the financial side, there are certain benefits that employers have to self-fund. It allows them to get rated for their own underlying health status. But that's also part of why moving all of those people into the individual market would be a stabilizing force. Yeah. Anytime you can get a larger risk pool, especially if they're relatively healthy people, actuaries will be happy with cost prediction.
Yeah, another thing that comes to mind, if I'm thinking about it correctly, is states with 1332 waivers. Really, they're paying for the cost of the premium reduction for the non-subsidized individuals. As Jason described earlier, the states will get pass-through funding on the APTC savings, which covers the cost reduction of the gross premium for the most part on the subsidized individuals. So as you bring all these presumably non-subsidized people in many cases, or most of them, I would suspect, into the individual market, that would be a significant number of individuals that the states would now have to fund that premium buy down for. So, they may eliminate those programs, and while there could be some morbidity impact of the risk pool changing, and it could be favorable from the group, the employees, the people currently in the employer group market coming over, states with really large reinsurance programs, north of 15 or 20%, there's a good chance that they would go away. So the individuals who are paying for that coverage on their own without an employer contribution to it could see significant increases in their premium rates. Again, if I'm thinking about that correctly.
So we continue to get questions about what happens if Congress were to extend the enhanced APTCs. If it sounds like if Congress passes and it's enacted by the end of this month, then it seems like there could be enough time to incorporate them, to change rates, have them reviewed, and have everything ready close to on time. But what happens if Congress doesn't act until later, until the end of September or the beginning of October? Would it still be possible for rates to reflect those changes? What would need to be done in terms of pushing back other types of deadlines? So the beginning of the open enrollment period, the end of the open enrollment period, what kinds of things would we need to think about in terms of those kinds of deadlines and dates? Annette?
So yeah, this is a challenge, right? That if you a lot of as we said before, enhancing or extending the enhanced premium tax credits would help to stabilize the individual market, particularly in light of some of the other policy changes that may have a little more of a destabilizing impact. So it would, extending the enhanced premium tax credits is something that a lot of people see as a positive to the market. The timing is important, and when you start encroaching onto set timelines, then it's really beyond control of the states, and it really is back to the federal government as to what kind of flexibility there is in lengthening the open enrollment period or delaying the premium rate finalization process. So I do not have a crystal ball, so I can't give any kind of guess as to the likelihood that the people in charge, Congress or CSIO or combination thereof, would change the current deadlines. But I hope some of them are on the call so they are aware of the challenges, and that if the enhanced premium tax credits are extended, that appropriate changes would be made.
Thanks, Annette. Go ahead, Jason.
I think it's really tempting for a lot of people to try and point at what happened in the end of 2017 with the end of CSR funding. We got, that was pulled on, I think, October 12th, which is after that deadline, but CMS extended some additional flexibility. But I think what gets overlooked a lot looking back at that is most states were requiring issuers to develop 2 full separate rate filings, one for if CSRs were funded, one for if CSRs weren't. That was fairly broadly thought that was going to be an either or, and we don't know which one. There's enough uncertainty around what might happen. Extending premium tax credits is a fairly expensive thing, and might be hard for Congress to do the full thing. What if they do a partial extension of some kind? Well, you're going to start to get to a place where issuers really haven't fully vetted a lot of those assumptions, and it will take more time than it required back in 2018. Even where if a plain extension of those were passed, a lot of the focus was shifted towards CSR funding as a result of a memo released by CMS back in May of this year. So it doesn't look like CSR funding is on the table, but that creates a whole array of different options that had to be looked at and considered. And I don't know how many issuers have a full clean APTC extension filing they can just pull off the shelf to substitute in. And that's going to vary a lot by state.
Thanks, Jason. And I'm going to turn back
really
to you.
quickly, if I may just you know, say a little more about what Jason just said, and you know, a little more briefly. In 2017, there was a binary option: CSR funding, CSRD funding. That was it. This year, it's much more complicated. There are many other permutations and combinations that states and different states required issuers to provide different scenarios. And so because of that, it's much more complicated. And also because of not knowing whether the extent to which the enhanced premium tax credits would be extended, if they were to be extended, there's just a lot more uncertainty and a lot more variability in the outcomes. So it's not that simple.
Nothing ever is, Annette, is it? All right, so Annette, you stay on hold because I'm going to come back to you with a question about market stability and what we think might be happening in 2026. But in the meantime, I got a clarification on the risk adjustment question I had earlier, and it really wasn't about risk adjustment at all, so I apologize. So Tammy and Jason, the coding question really is there any evidence or has anything been done to look at the provider side coding trends that maybe are they being used to increase provider revenue as separate from any coding for risk adjustment purposes? And you know, if that were happening, is that contributing to upward pressure on premiums? And you can say you don't know.
Yeah, that's a great question. I'm not aware of any research that has approached that specific issue, at least on the commercial side. There's some discussion around that in Medicare Advantage, but not yet on commercial risk adjustment.
Okay, thank you. So Annette, and this is a question I've gotten a lot outside of this webinar, is, you know, you walked us through what we need for market stability and also noted that some things are happening that are going to contribute to less stability. So kind of how risky are we in terms of instability for 2026, given the scheduled expiration of the enhanced tax credits, the more restrictive or strict eligibility verification rules? You know, what are we heading toward a premium spiral? Are we not? What does it vary by? I imagine this is not a yes or no answer. It depends. So can you walk us through some of the things that people should be thinking about?
Well, thanks for that very simple question, Corey. I think you answered your own question in that it depends, right? The first thing I learned about health insurance is that health insurance is local. And so the impact that you're talking about will likely vary by state, depending on local market dynamics, enrollment shifts, and also different states have taken different actions to stabilize their markets in anticipation of some of the changes that are currently happening. I think that, you know, as states look at their markets and how to stabilize it, I think it needs to be a very local consideration, the actual dynamics in the states. In some states, we've seen, for example, the 2024 experience come in a lot higher than was expected when the carriers were waiting for 2025. So this could be a major consideration for certain states. In some states, Medicaid redetermination was had a significant impact, either positive or negative, on the risk pool. So it's in my mind, it's really important to understand the local market dynamics, and there is no one solution that would impact all states in the same way. So that's another way of saying it depends.
Great. Thank you, Anna. I think that's a really great place for us to stop. I want to point out that if you'd like more information regarding the topics that we discussed today, you can find it on the Academy's resource guide on health insurance market dynamics. And here is the QR code that will lead you to the webpage. The webpage includes links to our recent issue briefs and other related papers, as well as comment letters and presentations. And here's a list of some of the resources available on the resource guide webpage. So that's all we have for you today. On behalf of the presenters, myself, and the Academy, thank you for attending today's webinar. For additional information or questions, please contact Matthew Williams or myself. Thank you and have a great day.